Okay, hi everybody. I don't know what time is it in your country. Here in Italy is 11:32 p.m. and I'm pre-recording this webinar, trying to be everything fine, because we know that during this period there are so many people connecting on the web that there are some problem of connection and transmission, and we know that there are so many people interested in this topic. So I'm trying to record at my home the webinar, and then on Friday at 5 p.m. Italian time, it will be transmitted for you, and then I will be there live for the Q&A session. I hope that everything will be fine during this webinar, and that you can hear well and see very well the slides and the video. I know for experience that it will be some problems with the video transmission, so probably sometimes it will be okay and sometimes they will be stopping, and so forgive me for that, but it is not an issue created by me, but for the over loading of um, information on the web. So please bear me also for my English. I'm not a native speaker in English. I'm Italian. My name is Magda Mensi. I'm a professor in periodontology and oral surgery here at the University of Brescia, Italy. And I work also in the biggest hospital of Italy, that is Pedalici of Brescia, as a dentist. And we are one of the most affected city in Italy and region in the world, and we are living the lockdown since more than 1 month, 6 weeks, yes, since 8 of March. Uh, but I worked in the emergency service, the hospital, and also in the private practice, um, giving just the um, urgent treatments to the patient during this time. So I have some experience in this topic, and during these 7 8 weeks I really study and elaborate all the evidence base that we have, the clinical data, the scientific data, the national and international recommendation and guidelines. And so what I want to do today with you is try to share all these information, all these indication and suggestions, and try to help you in during the recovery phase of this outbreak, of this pandemic. And the intention, the aim is not to give you the definitive, the final guideline, because we don't have final guidelines. We don't know enough about this virus to create some international guideline now, but we can share all the information in trying to be ready for the restart of our profession, especially for the non-surgical therapy, especially for the dental hygienists or for the dentists um, who give the non-surgical treatments to their patients, because we know that we are at risk as a category who work in in a very potential contaminated um, place because of the aerosol. And so what I want to tell you is this story about the aerosol. So how to contain the aerosol, how to reduce the contamination of the aerosol, and how we need to use the PPI in the right dental system to be protected and to protect our patients and the patient between each other. So before starting my presentation, I want to thank very much all my group, research group and work group, dental hygienists, students, dentists, young dentists, statistics, coordinator of dental hygiene schools, my co-workers, and especially my right hand, Dr. Eleonora Scotti, and my left hand, Dr. Silvia Marchetti, and Dr. Gianluca Garzetti, Simone Bossini, and Matteo Dalle, who helped me a lot, especially for this presentation. And you know that a big work is a teamwork, as during the clinical activity, also during the research activity. So thank to all my research group. And please again, forgive me for the mistakes with my English, but I hope you can understand. And if there are some errors or some problems, or you don't understand something, please write me the questions in the chat. And during the webinar presentation, I can take notes about your questions and try to answer immediately after the webinar during the Q&A session. Or you can contact me also on my email, magdamensi@gmail.com. So anyway, this is the outline of my presentation. So I'm gonna talk about the COVID-19 infection transmission in general, and also in specific about the routes of transmission in dental practice. I want to try to explain you how we can reduce and contain the aerosol and splatter in non-surgical periodontology, and especially when you decide to follow the protocol that we use, that is the guided biofilm therapy. And I want to thank a lot EMS for the support that give to this webinar, and also to the research on this new mini-invasive approach to the non-surgical therapy. And so especially the central part of this, the core of this presentation is dedicated to the dental hygienists, because they are scared in restarting their practice during and after the outbreak, because of the aerosols problem, especially if they are using the airflow systems, the ultrasounds, or ultrasound scalers, and so on. I will present the recommended measures during the outbreak and during the recovery phase. I'm gonna talk also about the diagnosis of the COVID-19 disease, because it's an interesting aspect when the in-office tests, serological tests, and molecular tests will be available also for the dental practice. So we try to make them clear. We don't have any specific indication or reliable data now, but I can give you some information about that. And then at the end, I want to show you and share with you the American Dental Association algorithms that are very nice, and they summarize very well the pathways to identify the urgent treatment, to identify the the risk patients for COVID infections, and how to treat the asymptomatic patients with a low risk of contagion in the private practice. So let's start with a mission that is, don't get infected, don't infect or make possible cross-infection. So this is the aim. But when I think about this aim, I think also about the preventive measure for the cross-infection controls in the dental practice that we need to follow independently from the COVID-19 infection or risk. And so when I think about the indication that internationally are approved, I think about some questions. So, for example, how many times have you lowered the mask under the nose or under the mouth sometimes when you were working before the COVID-19? Or how many times have you not rinsed with chlorhexidine? So you didn't use the pre-rinse before the treatment to reduce the bacterial load in the aerosol. Or how many times have you not washed your hands before and after putting on the gloves? Or how many times have you made too many patients wait in the waiting room without being able to change the air? Because we work too much, we work with so many patients during the day, we don't have the time to respect the time of the disinfection of the different areas. Or how many times have you not used the rubber dam for reconstructive therapy or for an endodontic therapy during an emergency treatment? Or how many times have you not used properly the sections, and especially the high volume ejectors during the aerosol treatment? So many times, because we were not scared about so infective, contagious virus disease. But now we are scared, and so we will follow strictly these infection prevention rules in the future, but they are not enough. So we need more. We need to add something in terms of PPI, and in terms of anamnesis, in terms of dental care system, in terms of times, in terms of cost, in terms of many things, trying to reduce the spread of this infection and try don't to be infected. So let's start with the infection transmission. So we are talking about this. We are talking about human-to-human transmission due to the droplets. This is the major route of transmission. So the droplets that we can create sneezing or coughing, creating these little droplets full of virus, and these droplets can remain in the air for many minutes, 30 minutes, and also 1 hour. And so the other people, we can inspire of these droplets from an infected patient and be infected. This is the major route of transmissions. And we also know that there is a mean incubation period about 5 days, is about 5 days, but there are patients without symptoms for 14 days. And there is one study who described one patient with 19 days of incubation. So there is a period where we don't know if the patient is sick, but the patient or the person could be contagious for you, for the other people. And you know also that these droplets can spread with the splatter, so with the big droplets that go down on the floor quickly. But also we know from some studies that some of these small droplets can remain in the air, so airborne, for a lot of time. So in average 30 minutes, but also more than 30 minutes. And these small droplets represented in this video could be inspired from other people if we don't respect the distance between each other of more than 1 meter. So this is really important also in a waiting room in a dental practice. And also when we talk crowdly, these small droplets could spread in the air. And so it is really important that during this phase we use at least a surgical mask to protect the other people from a possible infection. Okay, because we are all potentially infected and asymptomatic. So we need to protect the other and we need to protect ourselves. And we also know from some papers that there is a high expression of ACE2 receptor of 19 CoV virus on the epithelial cells of oral mucosa. And these authors describe that there are these receptors in the epithelial cells of salivary glands, ducts, oral tongue, floor of the mouth, base of the tongue. And so these infected cells could be a significant source of virus in saliva, and particularly early in infection. So we need more evidence about that, because it's not so strong demonstrated, but we have some indications. So we need to be protected when we treat the patients with or without aerosol. But what we are talking about when we talk about the non-surgical therapy, so we are talking about this. So we usually use the guided biofilm therapy protocol, and we used to be protected normally when we use this protocol, when we follow this protocol, because we apply this retractor, lips retractor, the name is Optragate, for having our two hands free, for using in one hand the high volume section, and in the other hand the airflow at the beginning to remove properly the guide of the therapy, so the color, the disclosing agent, to remove all the supragingival biofilm and the biofilm from the soft tissues, the gum, the back of the tongue, the palate. And then we remove the biofilm from the sulcus with the airflow, from the pockets with the perioflow, and we remove at the end the calculus, if there are any calculus, with the very thin tip, that is the perislim tip and the piezoceramic handpiece. So it is already a very protected therapy. But for example, before the COVID-19 outbreak, when we use the ultrasound, usually we were not used to use the high volume ejector. But now it is mandatory. So we need to use the high volume ejector not only when we use the airflow, if we combine the therapy as for the guided biofilm therapy protocol, but also when we use the ultrasounds. Any kind of ultrasounds or sonic scaler, we need to contain the aerosols with the high volume ejector. And I'm going to show you the data about the role of these high volume ejectors in terms of containing aerosol. So what about the aerosol and splatter in dentistry? So we create non-contaminated coolant water aerosol when we use the air polishing devices, when we use the ultrasounds or sonic scalers, when we use the turbine or the low-speed handpieces, and also with the air water syringe, and also during the hand instrumentation sometimes, combined with the air water syringe especially. But anyway, when we use the handpieces, we create the beginning and non-contaminated coolant water aerosol, like in the left side of the slides. But when these water and air and or powder contact the surfaces of the teeth, the gum, the soft tissues, we create a contaminated aerosol from patients. But the question is it always contaminated? And is it possible to create an aerosol virus and bacterial free? So we are working on that. We have no data now, but the aim for the future will be to reduce the contamination of the aerosol, also during the use of the handpieces. And we are not sure that the aerosol that we create is always contaminated. It depends. Sometimes when we use the powders, probably most of the organisms are killed by the powders before becoming aerosol. But at this moment, we don't know, so we need to protect ourselves and our employees in the dental practice. So the non-contaminated aerosol is this. So is what we create, for example, with the airflow handpiece. And with the new handpieces, we can create a very restricted jet, a very targeted jet, air, water, and powder jets, so we can contain very well the aerosol that we create. But we need to add the high volume ejector always. But what happens during a dental procedure? So the particle consisting of or conveying microorganisms can be atomized into the air during the dental procedures and are a potential source of acute or chronic respiratory disease. So depending on their size, these particles remain suspended as aerosols or fall rapidly and splatter on objects in their trajectory. But what is aerosols? So are particles less than 50 micrometers in diameter. And the small particles of an aerosol, 10 micron, 0.5 micron in diameters, have the potential to penetrate in the smaller passages of the lungs. And so the potentially carrying and transmitting infections in the low respiratory tract. And what is splatter? Splatter is airborne particles larger than 50 micrometers in diameter. So splatter droplets are readily differentiated from aerosol particles. They are visible to the naked eyes. It's something that we can see. And the results of the studies indicate that aerosols and transmissions of SARS-CoV-2 virus is plausible, but not demonstrated totally yet. But it's plausible since the virus can remain viable and infectious in aerosol for hours and on surfaces up to days. Some authors describe this. So again, we need to reduce, contain, and to be protected by aerosol during this phase and for a long time, because this virus will be with us for a long time. How far these aerosols spread and what level of contamination they cause in dental surgery. So there is evidence that dental aerosol can reach a distance of 1 to 3 meters from its source, causing contamination of distant surfaces. And splatter reach shorter distances and settles quickly, which makes dental aerosol a greater concern for oral health care personnel when it comes to airborne contamination. Again, one other important thing is to change the air in the room where we are working to make the aerosol go out and change and clean the air. And it is possible simply opening the window 5-10 minutes between each patient, for example. And to be protected, we need to wear different PPI compared to the normal one. It is not so different for the oral surgeons, for example, because we are used to use the disposable gowns and cover shoes and disposable cover caps, double gloves, and the shields or goggles and 2 masks. But for the general dentist or for the dental hygienist, probably is not so common. So we need to remember, for example, that we will need to use the FFP2 or FFP3 mask, so N95 code, and covered by a surgical mask. And we need to protect very well the eyes with the shields. This is very strictly recommendation during this period. But we will talk about these details at the end of the presentation, don't worry. What I want to show you is how we can really contain the aerosol using properly the guided biofilm therapy protocol. Because we normally use the Optegrade, we normally use the double ejectors, we normally use the high volume ejectors, and we normally use a very directed and targeted airflow. And now we will need to use the same tools also when we use the piezo, when we use the piezoceramic instruments, ultrasound instrument, or sonic scaler, whatever. And also for my colleague, for dentists, for my colleagues, we will need to use the high volume ejectors also when we use the turbines or the low speed handpiece. So in any case, when we create aerosol in our procedures. So the four hands work when we do something with the high-speed handpiece, for example, it is recommended. But with the guided biofilm therapy, and especially when we are using this protocol for prophylaxis therapy or for periodontal supportive therapy, we can work by ourselves. So it is easier because we can maintain a very good posture behind the patients and using the two hands, one for the handpiece and one for the high volume ejector, very well directed against the aerosol. So we can really control very well. And you can see on my shield that I don't have any droplets at the end of the therapy. So I think that we can work in a very very good control way using this kind of PPI and this kind of protocol, this kind of approach or tools. But also when you use the high-speed handpieces like the turbine, we need to use, and also when you use the rubber dam, for example, like in this case, I really recommend to use the four hands protocols and use the double ejectors, so the high speed and the low speed ejectors, so you can really control very well the aerosol. You don't see any droplets on the rubber dam. In this video, if you are able to see the video, I don't know, during the transmission of the webinar. So what the literature said about the aerosols and method of reducing airborne contamination. So in this paper from Harrell, we see that ultrasonic and sonic scalers and air polishing are the first producer of aerosol and airborne, followed by air water syringe and tooth preparation with air turbine handpiece. But we also see in the paper that the use of high volume evacuator will reduce the airborne contamination by more than 95% for the ultrasonic and 95% for the air polishing and 99% for the air water syringe. So please use this device and protect yourself with the PPI, with the right PPI, and use the pre-rinse mouthwash and filter the air or open the window between each treatment, each patient. And please do not remove the mask inside the operating area because the virus can remain suspended in the droplets for in average 30 minutes. So open the window often or leave it open if possible, and leave the alcoholic solution 65-75% to act for at least 5 minutes before drying. Leave the mouthwash to act for at least 1 minute because the contact time is really important to be effective on the viral capsule. And never put your hands in your mouth, eyes, or nose without washing very well the hands with water and soap or with the alcoholic solution. And after a dental procedure, if the operator removes a protective barrier such as a face mask to talk to a patient, for example, when the procedure is completed, the potential for contact with airborne contaminated material remains. So please don't remove the mask when you talk with the patients. It's something different that we need to learn to do. And remember that some study about the aerosol production demonstrate that also the no coolant water instruments can create aerosol in the operative sites, and the airborne material was spread for a distance of at least 18 inches, so 45 centimeters. So it's not so completely true that we don't create aerosol when we use, for example, the HANA instrument. So we need to be protected even if we decide to use the manual instrumentation. Protocols in dental practice. So probably you already know this picture from Peng article. I always put the reference on my slides, on the right bottom of the slides. If you need some paper, you can contact me by email and can share with you the full text. So in this picture, we can see that the risk of cross-infection it's possible between practitioners and patients because of direct or indirect contact. So from the infected patient who can sneeze or colds, and if he or she is not protected by a surgical mask, the droplets can infect other people or contaminate the surfaces, and then the dentists or dental professionals. And the same in the opposite side, we can create an aerosol on an infected patient, and we can create aerosols and infect other people or contaminate the surfaces, and so infect other people from an indirect contact. So all the measures that I will present are connected to this picture. The distance between people in the waiting room, the surgical mask on the patients when they are waiting, wash and clean and disinfect the hands of the patient when they arrive to your office before entering in your office. We need to wash our hands always in any moment. We need to contain the aerosol using the tools that I showed you before. We need to disinfect all the surfaces, not only in the operating room, but also outside in a waiting room. We need to change the air between the patients, and we need to avoid to treat symptomatic patients. And we will see this part when I will describe the triage questionnaire. But please don't be too much scared about this infection in the dental settings, because we know from our Chinese colleagues and authors that during the last 2 months of 2012 and the first day of January, when the virus was already there in Wuhan, in the hospital and the university, they continued to work on patients, and they had just 9 contaminated people, 3 doctors, 3 nurses, 2 administrative staff, and 1 postgraduate student. And probably the infection was limited because of medical masks and gloves were worn during the routine clinic work of dental practitioner, prevented further transmission. So also before using the right BPI like this, And before the introduction of all the different settings of the dental practice, they had just 9 contaminated people in the staff. And after the introduction of the right PPI, despite of increasing, very high increasing of contagious in the people, in the population, they treated more than 700 patients with emergent dental treatment, but no further cases among colleagues or patients. So that means that this system to organize the dental setting and the right PPI was very effective in prevent the transmission. What about the setting? So the triage and waiting area here is very important because we need to measure the temperature of the patient, to ask the questions that I will show you later. And if you have an asymptomatic patients without fever, you can treat the patient, and you need to provide a surgical mask for the patient, invite the patient to wash his or her hands for more than 20 seconds and wear the cover shoes, and waiting in the waiting room, maintaining a distance of at least 1 meter between the people. And in the operating room, the practitioner needs to wear the right PPI, so the FFP2 mask and the shields. Adding to the disposable gowns, cover caps, and cover shoes. And just in the clinic, with the isolation clinics for the COVID positive patients declared from the test, the swab and the PCR test, they had and they have and we have a specific area for these patients completely separated from the other areas, and we need more protection for these kind of patients. But normally in our routine practice, we try to visit just asymptomatic patients and or negative to the COVID test. So we try to summarize the recommendation. Remember that the hand hygiene has been considered the most critical measure of reducing the risk of transmitting microorganisms to patients, and also for the SARS is the same. The use of personal protective equipment is really important, and remember that we need the particulate respirators like N95 masks or the FFP2 or FFP3. So regarding the disinfection of the hands, remember that the soap is the enemy, the most aggressive enemy for the virus, because the soap have an hydrophilic and hydrophobic part, and hydrophobic part can attack the virus, and the hydrophilic part wash out the virus. So remove completely the virus from the hands. The alcoholic solution can kill or inactivate the virus, but can't remove totally the virus from the hands or from the surface. So we need to clean very well the surfaces, for example, and then use the alkalic solutions for disinfecting the surfaces. If we compare the SARS-CoV-1 and SARS-CoV-2 virus in terms of surface stability, we see that the SARS-CoV-2 virus was detected up to 3 days on the plastic and stainless steel surfaces. So it is mandatory to decontaminate and disinfect all the surfaces between each patients and at the end of the day. During the outbreak, the routine dental practices have been suspended, and all over the world, we were asked to treat just the emergencies or urgent and not controlled pain. But now in different parts of the world, we are starting again with the routine work. And so we need to be prepared to face this problem and to be protected and to control the spreading of the infections. So please, what I recommend is to come back to your routine activity just when you are ready to face the problem. So when you have all the PPI, just when all the team, all the staff of your clinic is prepared, and when you have elaborated all the protocols, you have changed your workflows in the office, the timing, and the number of patients that you can treat, when you provide the tools that you need to contain the aerosols, and when you are really ready to be safe. Okay, so don't do things just to do, but think about it and try to use the good sense and the evidence that we have right now to start again, and try to be update, because we will have more information in the next future. For the patients, leave everything, coats, jackets, bags, and so on, outside from the operating room, and maintain the distance of 1 meter or more between the other people, and wash the hands at least 20 seconds before entering the office. What we recommend is also a pre-check triage by phone at the beginning, and also when the patient arrived to the dental clinic. And what we recommend is to test the temperature when the patient arrives. If the patient has a temperature superior than 37.3 or 37.5 degrees, we need to postpone the procedure. And also, if we have a temperature below the 37.3, but the patient referred some symptoms or strict contact with symptomatic patients, we need to postpone the treatment if it is not urgent or emergent. This is the questions for evaluation of dental patients. So, do you have fever or experience fever within the past 14 days? Have you experienced a recent onset of respiratory problems such as a cold or difficulty in breathing within the past 14 days? Have you come into contact with a patient with confirmed 2019 cough infection within the past 14 days? That is the incubation period. Are there at least 2 people with documented experience of fever or respiratory problems within the last 14 days having close contact with you, so living with you or directly working with you at less than 1 meter of distance? Have you recently participated in any gathering meetings or had close contact with many unacquainted people? This is not possible now, but in the future probably yes. So we need to explore the story of the patient and try to select and treat just the patient who answered no to all these questions and without temperature. Or postpone the treatment at least 15 days or 30 days. You need to explain to the patient and to your employers and co-workers how to clean and disinfect the hands to spread the disinfection solution or soap in every single part of their hands and fingers and nail. So you can find these kind of videos everywhere in the web. And again, about the mouth rinse before dental procedure is mandatory to reduce the bacterial load, the virus load, and the fungin load, the spore load. But for the 19 COVID, we need something able to oxidate the capsule of the virus. So what is documented is the hydrogen peroxide, 1 to 3% for 1 minute, or 0.1, 0.2% iodopovidone recommended as well, or the cetylpyridinium as well. We now suggest 1 minute with iodopovidone 0.1, 0.2, but it's difficult to find it, and sometimes you have some problems of allergy. So what is easier to find is the 1 or 3% peroxide, and then 1 minute of chlorhexidine or chlorhexidine and cetylpyridinium. I know that EMS is working on a new mouthwash containing directly the H2O2 and cetylpyridinium, and we are excited to test this product in the future. Rubber dam isolation when possible, Optragate during the GBT treatment, but during all the treatment. So I use the Optragate for any kind of procedures in dentistry. For hands work with 2 ejectors, and anti-retraction handpiece are recommended. Disinfection of clinical setting, so you need alkyl solution or hypochlorite or peracetic acid, except chlorhexidine, that is not effective, so effective on the virus. And then manage the medical waste at the end of the day in double-layer yellow color medical waste package bags with a good ligation that should be used. So what is needed in terms of PPI and in terms of the system? So if you want to treat COVID positive patients during the outbreak, you need a very different level of protection, but probably you will never treat patients with a PCR positive test. So this is what you normally need for the treatment during this phase. So the first rule is not to treat symptomatic patients or positive to tests, but refer these patients, if urgent, to the hospitals, for example. For the symptomatic patients or negative to test, must be treated with adequate PPI and system. So, for example, the disposable gowns, caps, cover shoes, the shields, different kind of shields, and these are mandatory, the FFP2 or FFP3 with or without valve. Remember that if we have the valve, you need to cover this mask with a surgical mask, because this kind of mask protect yourself from the infection, but don't protect the patient to a possible infection by you, because there is the valve here. So you need to protect. Or you can use this kind without a valve, so you can use just the FFP2 or FFP3. The pre-rinse with the iodopovidone, cetylpyridinium, or H2O2, the alkaline solution, and the thermometer. These are different kind of high volume suctions with filter, without filter, other kind of protection of the lips, and other kind of high volume suction that you can use during your different kind of procedures that produce aerosol. Something about the diagnosis before ending my presentations and waiting for your questions. The diagnosis is certain just with a PCR, real-time PCR, on respiratory tract specimens, so from a nasopharyngeal swab. But this kind of analysis, so in the right part of the slide, so from the sputum or from the nasopharyngeal swab, is a very expensive test. You need hours in the laboratory to make these tests. Probably in the future we could have some quick tests, in-office tests, and probably from the saliva in the future. But now we need an external laboratory, and sometimes we have some false negatives also with the real-time PCR. And so we the authors try to add the serum, the blood test, to the PCR diagnosis. You know that the antibodies, the immunoglobulin, are produced by the immune system to provide protection against the virus, and that normally the level of IgM begins to rise after 1 week after the initial infections, while the IgG appears later than IgM, usually about 14 days after infection. But there are different data about this. This is one of the tests used in the clinical work trial, and they show these interesting graphs where they demonstrated during the incubation period we don't have IgM or IgG. Then when the symptoms start, like fever, we start to see the IgM production with a peak between the 3rd and 6th days, and then the IgM go down and the IgG from the 7th day start to go up, and they remain to protect from another infection for several years probably. But it is possible that in sometimes, and we don't know how long this protection will be there, but in sometimes we can be reinfected when the IgG level go down, but with a very low symptomatic reinfection with a low peak of IgM and another big peak and bigger peak of IgG. This is probably what will happen with the COVID-19. Okay, sorry, here. This is the test that we can have, and in some countries these tests are available, in some countries not yet, in some countries are not certified yet, but in the future for sure we will have a very reliable test to use in the office. At the moment, no reliable data are available, but we have some information that I want to share with you. The tests are very easy to do with the blood from a finger stick, for example, and we can have a positive result, a negative result, or an invalid result. So what does it mean? Positive. If asymptomatic, it is recommended to use the PCR test. If symptomatic, it is recommended to go to the hospital immediately. Negative test, no IgM, no IgG. If asymptomatic, indicates that there is no coronavirus, probably. If symptomatic, it is recommended to use the PCR. And invalid test, it is recommended to test again in strict accordance with the operating instruction, obviously. But how we can interpret the results? So if we have IgM positive and IgG positive, like if we have EGM positive and EGG negative, or EGM negative and EGG positive. This situation indicates that it may be a recent infection or a previous infection if we have just the EGG positive. But if we have EGM negative and EGG negative, that may be indicates that there are no infection, or there is not enough detectable antibodies in the early infection. So this is the problem. We have no reliable data. So we need always to add a second analysis to be sure to have or not have an infection. But different authors tested different kind of immunoglobulin test, antibody response, with directed against different protein, the internal nuclear protein or receptor binding domain, so the surface spike protein, with different sensitivity and different specificity. For example, here in this test, we have from 94% to 100% of sensitivity. So very good test, but tested just in very few patients. So we need more data to confirm this hypothesis. In this other article, they tested 397 PCR confirmed COVID-19 patients and 128 negative patients, and they obtained sensitivity 88% and specificity 90%, so very good. These are the results. So for the clinical positive samples, we had some patients who didn't have the immunoglobulin present, but the sensitivity was high, 88%. And in the clinical negative samples, we had just 12 patients with the positive serological test, so false negative, but the specificity was very high again, but not enough to be sure. What we know is that the fingerstick blood or the serum blood or the plasma venous blood give the same results. So what is sure that is that we could use the fingerstick blood. That is a very good information because it's easy to use in the office. And this is another article about the profile of specific antibodies to the virus. And this graph shows us another interesting information. That is, they found in the group of patients the EGM after 1 week and a very low level of IgG, and then they will be able to find the EGM and the IgG up to 5-6 weeks. That means that sometimes we could have infected patients after the onset of the symptoms, also for 5 or 6 weeks. This is the reason why, if we have symptomatic patients or with fever, it will be better to postpone the treatment of 1 month to be sure to have the patients without infection. And this is a summary of the utilization and indication of the test, the serological test and the PCR test from saliva when it will be possible in office. If we have negative results on the serological test, we could be in the incubation period, so we should have also the PCR test to be sure to have a patient not infectious. If we have a serological test with IgM positive, we have the virus for sure, so the indication is not to treat patients. The same if we have IgM and IgG, because we have already the inflammation, so probably we have the virus, so we need to postpone the treatment. But if we have just the IgG, we could have a remission patient still contagious, so it would be indicated to have also a PCR. But what is sure is that the biomolecular test, the quick test, will be a very important device if would be available for in-office test in the future. There are some companies who are testing these quick test in some hospitals and universities, and we are waiting for the results. And also the IgM and IgG test will be very important to detect the patient with the high level of IgG, so protected by the virus, because they can work safely with standard DPI, probably PPI. So to conclude, these are the American Dental Association algorithms, where they underline the importance of the PPI, the FFP2 mask, and the 14 days of quarantine for patients for a situation of high risk of infection. So in this chart, they show you what is an emergent treatment, like trauma, or like very important dental abscess with fever. So we need to treat the patient in emergency. Or what it is urgent, so a very high pain that we can't control with drugs, with medicine, so we need to visit these patients during the outbreak. If we need to visit these patients, we need to identify if the patient is infected or a very high risk of infection, so we need to administrate the questionnaire and measure the temperature. And if there are no risk, we can treat the patients in the private practice. And at that moment, that is the moment that we are facing now during the recovery phase, because we have asymptomatic patients. If we make a very good triage and questionnaire before visiting the patients, with no positive test on a PCR, because they don't need the test usually. So they arrive at the appointment, and if we need to make a procedure that produce aerosol, like a GBT, for example, like a professional dental hygiene with sonic or ultrasonic scalers, and we want to do that, we need to follow this arrow. So we need to have also the full face shields, the N95 respirators, the basic clinical PPI, so included the disposable gowns, caps, shoes, and so on. So in this situation, and using the high volume ejector, the Optragate, the right postures, changing the air and disinfecting the surfaces, you will have in a very low risk of infection. But if you don't have this system, if you don't have the right PPI, you can put yourself in a moderate risk or in a moderate high risk of contamination. So you need also to consider a quarantine of the operators if you have treated patients, suspected patients, without the right system and PPI. So the take-home messages as a positive messages. So any crisis is an opportunity to improve the dental care system, especially this one. So try to use this situation to give a better treatment, a safer treatment for your patient, and work in a safe environment. So try to reduce the contagion. And how to do that? With a good anamnesis and history about the COVID-19, so with a questionnaire and the telephonic triage, with a hand disinfection by you and your co-workers and patients, surgical mask for patient on hold, operator and assistant PPI, H2O2 and chlorhexidine rinse or cetylpyridinium to reduce the aerosol contamination, the Optragate or something like that to protect and isolate the area, double ejector, one of which is high volume, at least 300 liters per minute, and the air exchange, at least 5 minutes between each patient. So in this situation, the risk of contagion is very, very low. So try to start again, because our profession is so important and the prevention is so important, primary and secondary prevention, and also the active treatment, the non-surgical active treatment is so important for avoiding any other bigger problems and interventions and costs for the patients. So let's start again together. So I'm gonna be there on Friday after the webinar for your questions, or please contact me. So feel free to contact me on my personal email address, magnamensi@gmail.com. Bye bye and thank you. Okay, so now we are live. Thank you very much for following me during this hour and 10 minutes webinar. I hope you could hearing everything and understand the most part of my lecture. And so I received a lot of questions, hundreds of questions. So I'm going to try to answer to the not the most important, but the most frequent answers. And so we have 30 minutes or 35 minutes to try to answer to all these questions. So one of these questions are about the use of ultrasounds. So many dental hygienists ask me, so can we use the ultrasonics, the ultrasounds? Of course. So if you have all the recommended PPI, and you are able to put in act all the system that you saw and you learned during the webinar, so from the triage and from the history that you detected at the beginning when you receive your patients, to the time that you need to disinfect the area, to exchange the air, to change your disposable PPI, of course, and especially if you can use the high volume suction also with the ultrasound, because I think that the point is this. We are used to make a guided biofilm therapy for the users of this technique with the high volume suction when we use the airflow. But we are not used to use the high volume suction when we use the piezo and the last part of the therapy. So in this particular moment, during this recovery phase after the epidemic phase, after the outbreak phase, we need to use the high volume suction also when we use the piezo. This is the most important thing. Together with the FFP2 or FFP3 mask, in United States, I think that it is N95, the mask that is recommended, and together with your shield that you need to select for adapting to your goggles or to your lobes. And there are many brands, so you can find all the so different kind of shields or masks with incorporate shields that you can adapt to your goggles or to your lobes, to the magnificators. So don't worry, you need just to search, but there are. And I'm sure that during the next months we will have and we will find many different solutions to cover and protect our eyes. And why we need to protect our eyes, and I'm trying to putting together all the questions, making a story, giving a second webinar with the answers put together. Why protecting the eyes? Because we know that one of the transmission route of the infection is through the eye mucosa. So if the aerosol infected aerosol continue get to your eyes mucosa, you can be infected, as when you touch your eyes with your hands without washing your hands. If you have your hands infected, contaminated. So this is the reason why we need to protect very well the eyes, and not only the mouth and the nose. So coming back to the use of ultrasonics, yes, with the good triage. So we treat just asymptomatic patients, just patients without fever, patients who was not in contact with, were not in contact, personal contact with at least 2 people with symptoms or with fever or positive to COVID-19. And so we select our patients. And we know that the most infectious patients are the symptomatic patients. It is true that also the asymptomatic patients are can infect you because they have the virus, but we know that the percentage of completely, totally asymptomatic patients is just 4% of all the patients affected by coronavirus 19, and that the viral charge is lower. So we don't know if it is enough to infect other people. But anyway, we eliminate a big part of problem during the triage. Another problem, the asymptomatic patients, is the category, the percentage of the population that it could be in the incubation period. So at the moment of your visit, are not symptomatic, not in the 14 days before, but there are some patients with the longer period of incubation. But we have just one clinical study demonstrated that they had one patient with 19 days of incubation period. So, I mean, it's very difficult to visit a patient with the infection if you do a very good screening. But there is the possibility to have a complete asymptomatic patients, okay? So we need to be protected. So the first step, when you say hello and welcome to your patients, you need to ask him or her to wash his or her hands, or to disinfect for 20 seconds the hands with an alcoholic solution or gel before going in to your office, and then you need to ask them to maintain their surgical mask, at least the surgical mask, or better, the FFP2. In some countries, it is recommended, the FFP2, also for the people, not just for the doctors or nurses. But anyway, the important is to have the surgical mask, because they have not to contaminate the office or the waiting room or the surfaces if they cough or they sneeze or they talk loudly. Okay, so please keep your mask during the waiting time. Please disinfect your hands. You take the temperature, and you give the questionnaire, and you make another time the questions. Okay, everything in the questionnaire is negative. The temperature is below 37.3. The patient disinfected his hands. Keep the mask and put the cover shoes before entering, before going into your office. That is enough to avoid the contaminations of your surface in the waiting room and in the operating room. Then another thing that you need to do is to maintain the right distance between the patients in the waiting room. So if you have a small waiting room, probably you need to eliminate some chairs and maintain and keep just the 3-4 chairs that can allow to maintain 2 meters of distance between any patient. And so you can guarantee also the security distance between your patients with the surgical mask when they are waiting for their treatment. You need to ask to your patient to arrive to the appointment very sharply, so sharp, not before, because you don't want a lot of people waiting, or you need to ask them to stay out to your office in the case they arrive very early. And you need to protect your employees, like the secretary, with the PPI, at least a surgical mask, but better FFP2, because they stay all the day there, and so they need not only to avoid to infect the surfaces and people, because also the employers could be infected, but they need also not to inspire aerosol, contaminated aerosol. So they need a higher level of protection, and also the goggles. And then another step is to protect yourself and your assistant with, and this is another question, which kind of PPI? At least a disposable gowns to protect your own gown, and an FFP2 or FFP2 or 3 with or without valve. And this is another questions that I received. What is the difference, and why we need to cover the FFP2 or 3 if there is the valve? Why? Because this kind of masks protect you by the patients, but they don't protect the patients by you, because there is the possibility that your air go through the valve and infect your patient. Okay, and so you need to put the surgical mask above to have the function of the mask, the surgical mask, to protect the people by you. So what I suggest is to use in any case, the surgical mask above your FFP2 or FFP3 without bulbs, and change for any patients the surgical mask, so you can have always a good protection of your external part of FFP2, and you need to change your FFP2 or 3 any 4-6 hours if you continuously wear the mask, because with the humidity the filter goes away. But if you are able to remove after the patients aseptically your mask and put your mask on the air and in a very clean surface, you can remove it a little bit, drink some water, go to the bathroom, and then come back, put again your new disposable gown. This is the other PPI that you need to change between the patients, because it is really contaminated, and you touch your disposable gown and then you can touch the surfaces, so it is not good to stay with the same with different patients. So you come back, you put your FFP2, you cover your FFP2, you put your new disposable gown, your goggles and your shields and your gloves and your cover caps. And if you want, it is recommended also a cover shoes if you produce aerosol, so you don't contaminate your shoes as well. But or you need to disinfect your shoes after the treatment. And again, when you start your treatment, which pre-rinse it is recommended. Chlorhexidine alone is not sufficient, is not so effective against the SARS-CoV-2 virus. But it is a very good and powerful antibacterial and antiviral in general rinse. So what we recommend now here in Italy is the H2O2 1 to 3%, so 5 volume or 10 volume H2O2, gargling for 15 seconds, and then other 30 seconds in the mouth, like a mouthwash. And then following this, we ask for 1 minute of chlorhexidine with cetylpyridinium, that is effective against the virus, but up to now we don't have in Italy a concentration of cetylpyridinium really effective, because we have just a 0.05 or 0.06, and we would need at least 0.1 or 0.12% cetylpyridinium to be effective against the SARS-CoV-2. So at the moment we need to make a combination of pre-rinse, H2O2 and chlorhexidine with cetylpyridinium. In the future, probably EMS will be able to produce a mouthwash with both components, so H2O2 and cetylpyridinium, and it would be great because it's really effective, but not only. So we will have the efficiency of H2O2, and we will have also the substantivity of the cetylpyridinium that is effective for some hours. Other things other questions are about the coolant that. Okay. So we have time for 1 or 2 questions more, but I tried to summarize in this discussion all the questions. So if you can add some H2O2 or iodopovidone in your device, it could be useful, but we don't have any evidence about that. So you can do, but I don't know if it is effective. We are working on that. Also with the ozone, we are testing also this to produce an uncontaminated aerosol, but I don't have any definitive results, final results. And also another important thing is about the exchange of the air. The window is the best of things because in 5 minutes you can eliminate all the aerosol if there are any contaminated aerosol, or you need some negative pressure in your air system to collect the contaminated aerosol and filter this and produce some clean air. And remember that we don't know, and this is another important question that I received, we don't know at the end exactly if the aerosol created by a guided biofilm therapy or ultrasonic therapy or an airflow therapy or turbine utilization is really contaminated enough to infect the dental hygienist or the dentist. We don't know. There are so few cases of infection or dentists and dental hygienists during the outbreak period, also in the hospitals, who continues work with this kind of PPI. So we don't know. I recommend you to be protected and to follow the recommendation, and when you will be able to come back to your routine, because not in all countries we will be able to come back immediately to all the treatments. Probably in Italy after the 4th of May, in some country in June, I don't know. But when you will come back, the virus will be there again for a longer period. So please protect yourself and your co-workers, but don't be scared. You can do the things with all these protections. And remember the high volume suction or the external, or both, the external ejectors that are very important to collect more than 95% or 99% of the aerosol. So what remain probably is not even able to infect anyone. Okay, and what more? If I had 2 minutes more about this is another important question. The dental hygienist needs a nurturing support. I think that for the preventive care and for the supportive periodontal therapy, no, we can work by ourselves. I can use properly the high volume suction ejector without a nurser. And it's better. You can collect very well and better the aerosol. But if you have to treat a patient for many hours during inactive therapy, where you produce also blood and splatter and a lot of contamination, it could be fine to have an assistant. And in terms of time, remember that you need at least 20 minutes more for wearing and unwearing, and to have the time to disinfect the surfaces and change the stuff in the operating area. Remember that the alcoholic solution or the ammonic solution or the chloride solutions are effective against the virus on the surfaces just in 1 minute. So the time of application of these disinfective agent is from 1 to 5 minutes. So in 20 minutes, if you are quick, you can do everything. But for sure, we will need to change our way to work, and we need to have more time to dedicate to our treatments. And I think that is positive. So take this crisis as an opportunity to improve your work. And I love GPT, and I'm sure that we will continue to do this protocol, and we will improve the safety of this approach. Bye-bye. I need to say hello to everyone because I finished my time. Bye-bye.